Welcome. You're watching a symposium on the coordination of care for the treatment of early-stage lung cancer. The meeting was presented by a panel of multidisciplinary experts from The Ohio State University. Each expert spoke about a different topic on the coordination of care for early-stage lung cancer. In this video, Dr. Nicholas Pastis, an interventional pulmonologist, talks about diagnostic approaches for lung nodules.
I'm going to be talking about a diagnostic approach from the perspective of a pulmonologist or interventional pulmonologist that sees these patients. So one of the first things you want to do is stratify patients' risks of having cancer with these nodules. It's been shown that the prediction models, the Mayo model, for example, is good, but it may be equally valid to use an experienced clinician's predictors, and I'm going to go over some of those. So typically, the group we're able to biopsy, the group we're typically looking to think about surgery are the greater than 8 millimeter nodule. And then we want to assess the probability. The intermediate group is the group that we're stuck doing something about biopsying, whereas the very low risk group we can typically follow. The high risk group is what we're thinking may go directly to surgery. So very low, as we said, CT surveillance, low to moderate. And what we're talking about, typically most people say less than 10% risk of cancer is very low, give or take 5%. The higher risk are going to be the greater than 60, some say 65%. So that intermediate group is what's in between. So how do we risk stratify? And some of these features are incorporated into these risk prediction models. So low risk are going to be the younger patients, non-smokers, no other risk factors like not radon, not asbestos exposure. Regular margins tend to be more benign than spiculated. And then upper lobe is more common for lung cancer. So lower lobe locations tend to be other etiologies. And then high risk are the older patients, history of heavy smoking. We mentioned the spiculated or irregular margins in the upper lobe location. So how we stratify risk depends on the pretest probability of cancer, and that's why there's two different scoring systems. The first one I'll mention is the Lung-RADS, and that's specific only to screen-detected nodules. So we use the Lung-RADS, and that's radiology-driven, and it's 0, 1, 2, 3, 4. 4 has a 4B or 4X, and 4B is we're at my institution. I'm going to pursue biopsy versus follow-up. And then you've got the other, for incidental nodules, it's typically the Fleischner guidelines. And again, the difference here is you've got the low-risk patients. You don't have those high-risk patients lumped in here like they are all in the Lung-RADS group. So less than 6 millimeters if it's low risk, no follow-up even necessary. Whereas if they're high risk, you can go out to 12 months. In that 6 to 8 millimeters follow-up, for low risk, 6 to 12. And again, high risk is also 6 to 12. And then the greater than 8 millimeters is where you're going into other modalities. You're thinking about a closer follow-up, not letting the cancer start doubling. So a 3-month CT follow-up. If you're in that intermediate risk group, PET is particularly helpful, a little less helpful in the lower risk group, less helpful in the higher risk group when just looking at the nodules risk. And then for the higher risk group, greater than 8 millimeters, you are definitely thinking tissue sampling, close follow-up, and then PET CT. So let's go through a case. So this is a 51-year-old female. She presents to primary care for a routine checkup. She's asymptomatic, but she's a 20-pack year smoker. So she qualifies now for low-dose CAT scan for lung cancer screening. Her low-dose CT showed a 15-millimeter pulmonary nodule, left upper lobe, and it was a Lung-RADS 4B. So that was putting her in the intermediate probability group. So she was deemed a candidate for a biopsy. So what are your options out there? There's several modalities. I'm a bronchoscopist, so I must admit I like to do bronchoscopy, but I acknowledge there's other ways to skin the cat, for sure. So bronchoscopy is typically very poor if you don't have a centrally located lesion or you don't have an airway going directly to a lesion. That's changing. We're becoming much more adept at peripheral lesions, smaller lesions, with the advent of navigational bronchoscopy, guided techniques, and now even robotic bronchoscopy. The other advantage of bronchoscopy, particularly in the higher risk nodules, is it gives you an opportunity to stage the mediastinum with a very powerful tool, EBUS bronchoscopy, looking with ultrasound, sampling the lymph nodes in the same procedure. Image-guided interventional radiology has a higher diagnostic yield from the data we have for peripheral nodules, more in the line of 90%. However, it comes with a 25% pneumothorax rate and the bleeding risk. So those factors have to be taken into account and are somewhat patient-specific. Also may be more difficult to get to certain more central lesions or with emphysema patients with bulla in the way of the needle. And then surgery, certainly it's an option for a high-risk nodule. In my experience, a spiculated PET-avid right upper lobe nodule in an appropriate surgical candidate would allow diagnosis and treatment in the same procedure. A lot of times a biopsy is preferred even in a high risk because you don't want to put the patient through a whole lobectomy if it ends up not being cancer. But a peripheral one where a wedge resection can be done for diagnosis can then lead to treatment in the same setting. So really, really important in today's paradigm, very keen on the list of oncologists' priorities is biomarker testing and advanced stage non-small cell lung cancer. This paradigm is shifting now even to earlier stage 1B, and now there's evidence for 1B to 3A. It's not just all advanced stage. And then we definitely want to do testing for PD-L1 as immunotherapy is becoming part of the paradigm. So initially it was thought that these could be only obtained with core or surgical specimens, but it's pretty well validated that needle samples, EBUS, TBNA, can achieve high diagnostic yields in the 90% range for these tests. Keeping in mind, pleural effusions can be used, other lymph node FNAs. It doesn't have to always be done through bronchoscopy. So back to our case, she was deemed intermediate risk. We decided after discussion, shared decision-making to undergo a biopsy. It showed adenocarcinoma of this nodule. She was sent for PET CT scan for further staging, looking for lymph node involvement in the mediastinum or lymph node involvement elsewhere. So that brings up the issue of non-invasive staging. So we're typically talking about CT scan or PET scan. And then pathologic staging is where we're getting tissue. Surgical biopsy would also give surgical staging. So CT or PET cannot be relied on 100% to be accurate, and you don't want to under or overstage a patient. So pathologic evaluation, as we said, can be done from a variety of biopsy sites, and then surgical evaluation can be done at the time of surgery. And then it's important to keep in mind that the sensitivity and specificity of the non-invasive techniques, particularly CT scan, is not very good. 60% or so sensitive, specificity about 60 to 86. PET is a little better, a little more sensitive, 50 to about 80. Specificity 74 to 93. So in my experience, a PET-avid lymph node should not be automatically assumed to be cancer. You can't always rely on PET scan. Mediastinoscopy, unfortunately, in the literature is showing it as 78% sensitive. We still think of that as an important procedure when we have a high suspicion of PET-avid lymph node, enlarged lymph node. In my experience, patient going for surgery and the EBUS is negative, still should be confirmed at the time of surgery. Video mediastinoscopy, very good for getting at aortopulmonary window lymph nodes. So it can be used to stage also at the time of surgery, lymph node dissection, and has obviously very high performance characteristics. And then you can see how high the needle techniques have become, and that's why they're now thought of as first line for staging and diagnosis because of their high performance characteristics and their low complication rate. So EBUS or a combination of EBUS and EUS can be used. Practically speaking, we usually get what we need from the EBUS plus minus, not necessarily doing plus EUS. So back to our case, this patient was presented with this adenocarcinoma staged as a stage 1A. This was screen detected, and the multidisciplinary team reviewed the case and recommended surgical resection for cure. So that's it for me. Thank you for your attention.
Look for more videos on the treatment of early stage lung cancer from the experts at The Ohio State University.